Welcome to ATCM, the Emergency Medicine channel. Today we will be discussing a case scenario of bradycardia. So a 56-year-old male was rolled into ER with alleged history of odolum poisoning. The patient was conscious and oriented, and the patient had complaints of lightheadedness. His pulse rate was 45 per minute and he was connected to a cardiac monitor. His saturation was 98% in room air and his BP was 80 by 50 millimeters of mercury. So he was initially connected to the cardiac monitor. And during this time, we will do the parallel assessment of the airway, breathing, circulation. The patient was talking in a full sentence. There was no signs of airway compromise. His breathing part was normal. The saturation was 98% in room air with adequate breathing movements. And his circulation part, 2 large bore IV cannulas was asked to be secured.
2 large bore IV cannulas.
And
chest leads connected.
Chest leads was connected and the monitor showed rhythm of sinus bradycardia with a heart rate of 40. Since the patient had a BP of 80 by 50, which was fitting into a criteria of unstable bradycardia, which includes any history of hypotension, any ischemic chest pain, any features of heart failure, any altered mentation, we will take it as an unstable bradycardia and we will have to intervene. So the initial intervention 0.5 mg of atropine IV was asked to be delivered. So give injection atropine 0.5 mg IV.
Injection atropine 0.5 mg given.
So injection atropine was given and we had checked for the response. So the patient's heart rate was improving from 40, it was improving . But it was a transient response that it again went back to 41. So we could take it as not responding to atropine, and the second line of management we will have to go for, which is a transcutaneous pacing. So we will have to connect the patient to the pacing pad should be attached and we have to go for a transcutaneous pacing. So 2 pacing pads have to be attached, one below the right clavicle and one at the apex, and we have to change the defibrillator mode to a pacing mode, and we have to select the rate where we have to require the pacing, and the milliamperes of current should be also set for. Before this thing, we have to get the consent. The patient is conscious. We will have to give adequate sedation, and we have to have the crash cart and emergency intubation drugs, everything set ready also.
Rate set at 60. Pacing ampere gradually increasing from 10 milliampere.
So we have to increase the pacing ampere till we get the pacing capture beat is.
Electrical capture occurred at milliampere of 20. Can you check for the increase in BP of sensor?
So the rhythm got captured at 20 milliampere, and we are transcutaneous pacing was done.
What's the BP now?
BP 130, 80.
So now there is a good physical capture also.
If there is any improvement in the vital signs or in the symptoms change in the mental status or anything, we can know that it's adequate response is there with the pacing. So after the pacing is done, we will have to get the expert cardiology opinion and ideally shift the patient for a transvenous pacing. This is the basic algorithm of bradycardia according to the AHA guidelines.